Chairman Brown. Senator Berger.
Here.
Senator Brown. Here. Senator Huff. Senator Lewis. Senator McCreery. Senator Schroer. Here. We got a quorum.
We have a quorum. When a witness is about to speak, he or she should introduce themselves and address their comments to the committee. Witnesses need to keep their comments relevant to the bill being heard. Each witness must complete a witness appearance form and leave it on the desk. Only individuals or organizations testifying in person will be recorded in the committee minutes. Members of the committee, remember to speak into your microphone so those listening online can hear what the committee is discussing. After the sponsor presents the bill, we will proceed first with those testifying in support, followed by those testifying in opposition, and concluding with those testifying for informational purposes only. For committee schedule purposes, I may have to limit some time for these testifying. Today we'll be hearing 4 bills.
What he said. First bill up, Senate Bill 292. Senator Crawford, whenever you're ready. Senator Crawford, if you'll let's pause here for a second. We're going to go into executive session. I make a motion to move into executive session. I have a second. We're in executive session. I move that Senate Bill 190 be brought before the committee. Do I have a second? I have a second. All those in favor say aye. Aye. Opposed, no. Ayes have the bills before the committee. I move that Senate Bill 190 be voted out of committee. Do pass. Do I have a second? I have a second. This is my bill. I present a bill, Senate Bill 190. It established a tax credit for certain engineering degrees. Is there any discussion? Hearing none. Ask you to call the roll to vote Senate Bill 190 out of committee. Do pass. Aye.
Chairman Brown.
Aye.
Senator Berger.
Aye.
Senator Brown. Aye. Senator Huff. Senator Lewis. Aye. Senator McCreery. Senator Schroer. 5-0.
By your vote of 5-0, the motion carries. I now move that Senate Bill 61 be brought before the committee. Do I have a second? I have a second. All those in favor say aye. Aye. Opposed, no. Ayes have it. This bill is before the committee. Excuse me. I move that Senate Bill 61 be voted out of committee. Do pass. I have a second. I have a second. I presented this bill as well.
Ben Brown.
Senator Ben Brown
Sorry.
presented this bill 61. It allows for temporary licensure for individuals with work experience in certain occupations, profession, and other jurisdictions. Is there any discussion? Hearing none, ask you to call the roll to vote Senate Bill 61 out of committee. Do pass.
Chairman Brown.
Aye.
Senator Berger.
Aye.
Senator Brown.
Aye.
Senator Huff. Senator Lewis. Aye. Senator McCreery. Senator Schroer.
Aye.
5-0.
By your vote of 5-0, the motion carries. I now make a motion to move out of executive session to resume our regular hearing. I have a second. We are now back in regular session. Senator Crawford, whenever you're ready.
Thank you,
Thank
Mr.
you for your patience.
Absolutely. Thank you, Mr. Chair, members of the committee. For the record, Sandy Crawford, District 28. Thanks for the opportunity to bring before you Senate Bill 292, which would modify the rulemaking authority dealing with, actually it does a couple things. First thing it does is it will address who has the rulemaking authority dealing with pharmacy services inside hospitals. There's been some confusion as to whether the Department of Health and Senior Services can promulgate the rules or the State Board of Pharmacy. Senate Bill 292 will streamline the jurisdiction by clarifying DHSS has the sole authority to promulgate rules governing the pharmacies in hospitals, and the Board of Pharmacy will continue to maintain its ability to regulate the pharmacists and the pharmacy technicians. The other thing that it does, I have several small hospitals in my district, and whenever I meet with them, almost every time I meet with them, one of the things they bring up is the, I guess I'll just say, slowness of the approval of licensure for the physicians. I've heard it year after year. And so the other part of the bill is dealing with the statutes that govern that licensure. It would do away with some outdated provisions that we feel unnecessarily delay that licensure. And I understand that there's some opposition to this, but my real motivation is if we can streamline it, let's streamline it. But my real motivation is to get it to a place where we don't have to call in and say, what's the holdup on this licensure? So I'm all ears. If somebody has other ideas, I think you're going to hear some testimony against it, but I'm hoping that we can work something out to where we can get an acceptable time where these licensures are actually approved. With that, I'm happy to answer questions, but I do have at least one of my hospitals I think is here to testify as well.
Thank you, Senator Crawford. Any questions for Senator Crawford from Kenny? Seeing none, first witness to testify in favor of. Whenever you're ready, please come forward.
Thank you, Senators. Jane Drummond, Missouri Hospital Association, here to testify in support of this bill. As Senator Crawford said, this does a couple of different things that we're in support of because we think they will improve patient access to care as well as patient safety. With respect to the physician licensure process, we have approximately 7,000 physicians that work for our hospitals in the state of Missouri. We are finding that it can take up to 16 weeks to get a physician licensed in the state. We think that is just because the process has become unduly burdensome. There are just so many materials that an applicant has to gather and submit themselves to the Board of Healing Arts in order to get a license processed. That is part of the reason why it takes so long. We think this bill will actually streamline what the board requires to be examined for licensure, and it also requires them to verify things like education status, licensure in other states by a simple electronic screening process. Right now, applicants have to go out, gather all of those materials, and manually submit them to the board. And it just simply takes too long. And I think probably opponents of the bill will say the Board of Healing Arts is in the process of implementing an electronic system that will automate a lot of those processes. That's great, and we are all in favor of that. But that doesn't really help if you're still having, as a busy physician, you're having to go out and get all those materials and bring them in and submit them to the board, whether you do it by mail or whether you do it electronically. So we do think this contains some provisions that will really streamline the process. And it exacerbates when we already have a physician shortage in the state. So if it can take 10, 12, 16 weeks to get a physician licensed, they don't even start their credentialing process with the payers until that license is in place. So you hire a physician, and it is 4-6 months before that physician can actually start providing patient care and be reimbursed for it. So it's really important to us, and we are definitely in favor of that. The pharmacy jurisdiction provision that Senator Crawford mentioned is really cleanup language. DHSS has always regulated inpatient pharmacies. There was a bill passed about 5 or 6 years ago that created dual jurisdiction for the Board of Pharmacy and DHSS in a very narrow scope. But the language was ambiguous, and so it makes it appear that now all rulemaking has to go through both agencies, and that is not correct. There are a couple of different provisions in the bill that deal with controlled substances that we support. One has to do with delivering controlled substances to a physician as opposed to the patient. Existing law says you cannot deliver any portion of a controlled substance to either the patient or the person that dispensed it. So if you have a controlled substance therapy, like an infusion therapy, that the doctor administers, that gets delivered to the patient, and then they take it into the physician to be administered. That physician doesn't know where that drug has been. It could have been sitting on somebody's front porch for 3 days in summer heat, and so they don't know if it's been compromised or not when they administer that medication, so this would clean that up. And then the bill finally would also allow for a BNDD or a controlled substance registration for outpatient hospital clinics so that they can do telehealth prescribing of controlled substances for substance use disorder and behavioral health. This is primarily things like ADHD drugs for kids that right now are being prescribed via telehealth under federal waivers, but when those go away, will require an in-person visit, and a lot of those patients may not be compliant with those treatment regimens going on if they have to come in and do that inpatient visit. So we are in support of this bill.
Thank you, Jen. Are there any questions for this witness? Senator.
Good morning. I absolutely support streamlining the process to get our physicians up and running here in the state of Missouri. I sponsored the Interstate Medical Licensure Compact. So how does this comply with that, or, how does that work with the?
It's complementary to it. So if you have somebody coming in from a compact state, they go through that compact process, and that actually has a time frame of 45 days. So in some sense, it is easier to go get licensed in another state and then come through the compact to get licensed in Missouri, as opposed to just initiating the process in the state of Missouri, because there are there are just more requirements for an initial license in Missouri. Part of that is statutory. I mean, by statute, they have to submit high school transcripts. That seems silly. If you've gotten through medical school, you probably got through high school, but it's an antiquated statute, so it requires all of these things to be submitted that probably don't make sense anymore.
Okay, and then there was some language about unaccredited education or something. Does that have to do with assistant physicians at all?
No, it has to do with your where you do your residency.
Okay, thanks.
This kind of goes back to Senator Brown's bill that he had the other day. I had this bill for military spouses back in 2020, which does essentially the same thing. It deals with any professional licensing, which those boards have the ability, but they don't have to, because it has to come from a state that has equal to or above the standards of what Missouri has. But they have to grant the license within 30 days.
Correct.
So
that's what we're trying to solve.
This is what
It's
we're
just
trying
the
to
time
accomplish.
frame. Yes.
With everything now. Okay. Any other questions for the witness? Seeing none, thank you. Next witness testify in favor of the bill. Whenever you're ready, please come forward. Are there any witnesses to testify in opposition to the bill? Whenever you're ready.
Mr. Chairman, members of the committee, Jacob Scott here representing the Missouri State Medical Association and the Missouri Association of Osteopathic Physicians and Surgeons. Just wanted to go on record in opposition. I had a chance to talk to the sponsor briefly and her chief of staff, which I'm grateful for, to be able to walk through some of our concerns. Just wanted to say off the top, that we share the same desire to get these applications processed in a timely way. So we're ready and willing partners, and I've worked with some of the stakeholders with the hospitals to see if we can find a way to make that happen. Couple points of relevancy that I think Jane mentioned. One is that there is a new online system that just very recently came online, so we are hopeful and optimistic that this change in platform will help speed up the process for some of that. We just really don't want the board, even though I don't represent the board as their lobbyist, I just represent the physicians that interact with the board. We just want boards to be treated equally and, not to have a punitive nature for one over the other. So I feel like that we can come to some sort of agreement on this and speed up these applications. And then the second thing I wanted to mention is in the bill, it talks about how after 45 days, an application would just be deemed approved. We feel that that's not the correct way to go about this because, if it takes 45 days or longer to approve an application, there could be a substantive reason for that. So maybe they should be deemed denied at a minimum. But we're willing to work with the sponsor and stakeholders to see if we can't find something. But I think there is a relevant conversation about just tabling this entire piece from the bill altogether and jettisoning it for this year. And if there still remains a process application problem next year, we could address it. And for that, I'm open for questions.
Thank you. Any questions for the witness? Senator Brown.
So under current law, are there any time constraints for the approval process?
Not that I'm aware of. I could be wrong about that, but I'm not aware of any time constraints.
What, in your opinion, would be an adequate amount of time if there were a provision that required or that applied automatic approval at a certain threshold?
I'm not prepared to say a specific time that my board has authorized or anything like that, but I think just given the testimony, it seems 45 days is reasonable, but we just don't want to deem those applications approved. They should probably be denied, but we should pursue a goal of getting these things processed as quickly as possible, and I think that's up to you guys to decide how long the board should have to process these applications.
Thank you.
If it was up to me and they can't process a license in 45 days, I'd get a new board. because, that's the one thing about bureaucrats of government. We are not efficient.
Yeah, I just want to read.
There is no reason why they can't approve these licenses within 30 days. That's why I had the bill in 2020 with the military spouse deal. It's full reciprocity on any professional license. It doesn't matter if you're an engineer, a teacher, a lawyer, a doctor, whatever. And my biggest regret on that is we just didn't go ahead and do it with all professional licensing then, because we literally had basically no opposition to that bill, so I'm not really sure why it's a problem now. But, I would talk to your board if they can't process licenses within 45 days. That's a serious problem. Any other questions for this witness? Senator Schroer, or Senator McCreery.
Good morning. Who are the actual people that are doing the processing of the applications and all the documents? Are they state workers, or are they outside of the realm of the state of Missouri?
It's my understanding there's state workers that are employed by the board.
Okay.
Yeah.
Well, I think, I've been in this building in many different capacities since 2000, and I've seen some pretty dramatic cuts in staff that are supposed to be doing this work. So I think it's also might be something we could look at, like if we could add, some people or something, it might help. So I just want to, throw that out there as well. I think when we get complaints as senators on things taking too long, whether it's Department of Revenue or whatever, it's often because, we don't have enough people to actually do the processing.
Yeah.
So.
And to be clear, again, I don't represent the board, so
I
there may be
understand.
someone in the audience that could better represent the staffing issues
Okay.
and processing issues. We just represent those that interact with the board, and we have a mutual interest in these applications being processed very timely. So,
Very good. Thank you.
Senator Schroer, do you have a question for the witness? Seeing none. Any other questions for the witness? Seeing none. Thank you, Jacob. Are there any other witnesses testifying in opposition to this bill? Whenever you're ready, please come forward. Seeing none, Senator Crawford, do you have any closing comments?
I appreciate your time. Thank you.
You're very welcome. Next bill up, Senator McCreery, Senate Bill 431, whenever you're ready.
Good morning. Thank you, Mr. Chairman, for hearing Senate Bill 431 this morning. I am State Senator Tracy McCreery. I represent portions of St. Louis County. Senate Bill 431 kind of connects to the spirit of what we were just talking about. It reminds me of what we just did with Senator Brown's bill. I really feel like this is a government efficiency streamlining kind of bill. Senate Bill 431 would modify the requirements for licensure of a speech pathologist or audiologist by providing for completion of a clinical fellowship under the direct supervision of a licensed speech-language pathologist in good standing, rather than under the direct supervision of a person licensed by the state of Missouri in the profession. So I believe that this Senate Bill 431 is an important change. Right now, the situation is there are significant challenges for speech-language pathologists who have completed their clinical fellowships in other states. So they've completed their fellowships in other states, but want to pursue licensure here in the state of Missouri. And the current law creates a barrier for professionals who received high-quality training in other states outside of Missouri, but they're unable to meet our specific licensure requirement here in the state of Missouri. So speech and language pathologists wishing to practice or move to Missouri to provide their sought-after profession are actually being turned away because of the way our state law is written. So this language seeks to just reduce barriers for people that are highly trained, and I think it will ultimately lead to more professionals being licensed and wanting to practice in the state of Missouri. Happy to take questions.
Thank you, Senator. Any questions for Senator McCreery? Seeing none, are there any witnesses testify in favor of the bill? Please come forward when you're ready.
Mr. Chairman, members of the committee, my name is Brent Hemphill. I'm here on behalf of the Missouri Speech, Hearing, Language, and Association. I want to thank the senator for bringing this bill forward. We, too, passed a compact in 2022. It is not quite up to par yet. Not all the states have adopted the same legislation, but when we passed that, we had to have a clinical fellowship for folks to get an SLP license in Missouri. The statute says to do a clinical fellowship, you have to have a partnership with a fully licensed Missouri SLP. It's essentially, it is your residency as a physician. You have to be trained under them for 1 year. All we're doing is removing the word Missouri and adding the words in good standing. So you have to be a fully licensed person in good standing in the respective state. That is all this bill does. Be happy to answer any questions.
Thank you, Brent. Are there any questions for the witness? Seeing none, are there any other witnesses testify in favor of the bill? Whenever you're ready, please come forward. Any witnesses testify in opposition to this bill? All right. Seeing none, Senator McCreery, you have any final comments?
No, but thank you for hearing this bill.
You're very welcome. All right. What we're going to do next, we're going to hear Senator Schroer and Senator Lewis's bill at the same time. That would be Senate Bill 144 and 179. Whenever Senator Schroer, Senator Lewis, whenever you all are ready, have at it.
Same time. Okay. Good morning. For the record, I'm Patty Lewis, State Senator for District 7. Mr. Chair, distinguished members of the committee, it is my honor to be here to present Senate Bill 179 along with my colleague in his Senate Bill 144. Before I dive into what my bill does, I think it's important to speak to why it's so critical. There is a healthcare shortage in Missouri. Every county in the state, except for 3 counties, are considered healthcare deserts. During COVID, Governor Parson waived several restrictions for APRNs, and there were no reported issues during that period. Unfortunately, the waivers have expired, and the restrictions are back. You may hear from witnesses that the sky is falling if this bill passes. But the truth of the matter is 27 states have passed transition to practice, and they have not repealed the laws. Collaborative practice is also very expensive. A survey from Mona indicated that paying a physician can cost up to $50,000 plus per year. And you'll hear from some witnesses who can speak in detail. What my bill does, 179, it is a great solution for our constituents who need access to health care, and it removes unnecessary barriers. It does 2 things. Transition to practice after 2,000 documented hours with a collaborating physician. It also allows APRNs to prescribe Schedule II medications for behavioral health patients. We made some changes for Schedule II with hospice patients, and this expands it to behavioral health because we have a mental health crisis here in the state. While I believe APRNs should have full practice authority, transition to practice is a good compromise. 27 states plus Washington, D.C. have granted full practice. Missouri is one of the most restrictive states in the country for nurse practitioners. And where I come from, in Kansas, across from where I represent, they have full practice authority, and many nurse practitioners are moving across the state line or deciding to move across or work across the state line versus here in Missouri. APRNs are highly trained and have clinical experience. Research shows that they have consistently demonstrated to provide safe, effective, patient-centered, efficient, and evidence-based care. So,
all right, thank you, Senator.
Take over.
Thank you.
Before we ask any questions, go ahead. We'll ask questions combined when Senator Schroer gets done. So
I appreciate it. Thank you, Mr. Chair, members of the committee. For the record, State Senator Nick Schroer from the 2nd and St. Charles County, presenting Senate Bill 144, which seeks to reform regulations concerning advanced practice registered nurses. Senator Lewis said APRNs within the state of Missouri. This transition to practice bill brings our healthcare system into the modern day, empowering nurse practitioners, highly experienced medical professionals, to practice to their fullest extent of their education, their training, and their abilities. This legislation phases out archaic regulations which the majority of other states have already repealed, which has statistically been shown to increase patient access increase patient outcomes, decrease healthcare costs by simply letting these providers treat Missourians exactly how they've been trained to. You'll hear that many states, like Arizona to Oregon, where full practice authority has been passed, led to fewer preventable hospital admissions and better management of chronic diseases. In Missouri, where a total of 109 out of the 114 counties face horrendous primary care shortages, again, that's 109 out of 114, this legislation has been proven to provide more experienced face-to-face care from providers who know their patients and the issues that they are experiencing. Senate Bill 144 isn't just a run-of-the-mill regulatory reform. It is a lifeline for the state that ranks in the basement at number 42 of 50 in overall health care. Our physician shortage of 3,700 physicians in the next 5 years will be countered by tapping into the experience and skill set of our trained nurse practitioners, just as we have seen in the majority of other states across this nation. Finally, from rural Missouri to the urban corridor, Missourians will have access to affordable, accessible, timely health care in the state of Missouri. For those reasons, I urge you to prioritize the health care and the future of your constituents by voting yes on these two bills.
Thank you. And excuse me, I have a couple of questions, and I don't want this to sound derogatory, but why not just go to medical school?
Well, the medical doctors are treating patients in a totally different manner. If they wanted to go to medical school to provide that level of care, then they would. So what this is doing is getting us in line with the other states that have recognized you go to school, you do all of your training, you do all of your patient hours, and still in the state of Missouri, you're restricted on your ability on how to treat these patients. And other states have embraced all of the education, all of the training. So we're not advancing anything that they haven't been taught to do. We're just saying in the state of Missouri, some of these archaic regulations that have been on the books for 30, 40, 50 years that have other states have recognized are not needed. That's why this bill is necessary. So we're not expanding this to where they're going to be, performing brain surgery or heart surgery, which doctors are trained in doing, physicians are trained in doing, and there's a larger payday for them for that, and there's a larger liability for them for that as well. All we're trying to do is repeal some of the archaic regulations to transition them to the fullest practice that they've been educated and trained to do.
So would this be a licensure like under the Board of Healing Arts, or would they have their own board? Or, how does that work with like the licensing and the insurance and all that?
So they'd have to get, once they're not part of the collaborative practice agreement, they would have to have their own liability insurance. Other states do the same exact thing. A couple of years ago, I think it was 2 years ago, when we made a couple of provisions, nurse practitioners had it wasn't a license, it was a certificate. So we gave them that license, so now they'll still be licensed, controlled, just as they are currently.
So, and final question, we'll get to the other committee members, but Senator Lewis, you mentioned Kansas. I can see where Kansas would want to do something like this. there's literally more cattle in Kansas than there are people, so it's very rural. And so, like the other states that do that have already eliminated the collaborative practice, are they states like Kansas that are rural and like not heavily populated, or?
No, there's a map that we can pass out to the committee members, and I don't think we've got those over to you, but there are a variety of states from up in the Northeast that's more condensed to Midwest to the West Coast. So there's definitely a variety of different states.
Okay, thank you.
And Chairman, we've seen since I've had this in the House and in the Senate, we've seen a lot of different providers that have actually picked up and gone to Illinois, to Arkansas, to Kansas, to Iowa, because they can actually practice to their fullest extent.
That sounds pretty desperate to me, going to Illinois from Missouri. Come on.
Well, hey, where you can actually, it'd be like in the practice of law. If Missouri still treats attorneys as a paralegal, and I can go to Illinois, I can go to Arkansas, I can go to Tennessee and be treated like an actual fully fledged attorney like I was trained to, yeah, I'd be going.
Right. All right. Senator Brown.
So I recall when there was a hearing for this bill previously at some point over the last couple of years, just to clarify a couple things. So this is aimed at simply allowing nurse practitioners to, practice their full scope, but it's not creating any new ability to expand out of that scope in the area to where they don't have specified training or experience.
Correct. It's not, it's just allowing them to practice. I think, just, I'm a RN BSN, and I know what I'm trained to do. I'm not an APRN. I'm not a physician. We're all healthcare team. I got, so it's just, what they're trained to do.
Okay.
Yeah, and to your point, I mean, this is not changing anything that they have been trained to do, educated in doing. I know there are certain specialties that APRNs would have to get certain certifications for. Similar to an attorney, I'm not going to do bankruptcy law. I've never done that. That'd be malpractice. So in the same realm, if they want to get those specialties for, family nurse practitioner or geriatric, they would have to go and get certified accordingly.
One more question. I believe when you presented this bill in the past, you stated a statistic, I believe, about the shortage statewide. Do you have any other information? Was there information presented pertaining to shortages by counties or anything like that?
Yeah, I think we had a handout. Last year and the year before of the shortages by county. I'll let you present that if you would like. But briefly, I know we have in the U.S. there are studies that show that by 2034 there's going to be anywhere between, and this is staggering, anywhere between 37,000 and 124,000 providers nationwide. In the state of Missouri, there was a shortage, I think, roughly around 3,000 by this year. And currently, when we're looking at the hospitals that are closing, there were 15 that were closed in 2014. All of 114 counties had shortages in the mental health provider arena, every single county. 109 counties out of 114 have a primary health care provider shortage. And the United Healthcare Group, or United Health Group studies have shown that this transition to practice approach in the state of Missouri will reduce that shortage by 70%. Senator?
And then, Senator, one of the handouts is statistics per counties from October 2024, and it's a map of the state of Missouri, and the only counties that are not considered a healthcare desert are Platte, Clay, and Cass.
Okay, thank you.
Senator Berger.
To inquire, please. As the population gets older and we have less people to replace us down the line, we see such a lag in appointments in southeast Missouri already to get into family care. This just kind of makes sense to me that we would do this. I think there are plenty of patients to go around for everybody. That's kind of my feelings. Any thoughts on what I just said?
Yeah, this is something that we stressed in years past, the baby boom crisis. One-fifth of Missourians will be over the age of 65, 87% increase since the year 2000. So you're exactly right. And that's where, with the doctor shortage and more patients kind of aging out in that baby boomer category, we're seeing a lot of wait times. We're seeing a lot of areas where you can't find a provider. Now, some things have helped with the advent of telehealth that we've tapped into and getting rid of the mileage restriction on the collaborative practice agreements. But still, I mean, you can talk to some of the businesses. I know Amazon in my community is wanting to have their own nurse practitioner on site for their workers. In the state of Missouri, they can't do that. Other healthcare providers are saying that, or other businesses that want to provide healthcare to their employees are waiting for this bill to pass as they see there is a massive shortage, and they want to deal with that on the front end by allowing providers to be within their facility.
Well, another thing that kind of concerns me when I look at this map and I see Missouri and since we're in SEMO, that access to Kentucky, Illinois, Tennessee, and Arkansas is pretty easy for us.
Right.
So I think we'd even have more of a shortage, maybe the rest of the state, considering we're kind of a border corner of the state, and that concerns me also.
I agree.
Thank you.
How many? What's the salary difference between a licensed physician versus like a nurse practitioner?
I think you'll have some here today to talk about the cost of the collaborative
That's a
practice
huge
agreement.
concern of mine, because let's not kid ourselves. These hospitals are ran like businesses. They're more about the bottom line versus patient care. And what concerns me is if you can make $50,000 a year less being a nurse practitioner versus a physician, why would you waste the money and energy and time to go to medical school? I mean, I have a son in veterinary school right now, and it's very expensive. It's only about $20,000 total less than what it is to go to medical school. The requirements are the same, but, they had 3,500 people apply to that, and they take 120. So, I mean, you're kind of cherry picking the best of the best to do things like that. And I hope we don't And I understand what you guys are saying, and like I said, I'm not saying I'm against this deal, but I hope we don't dilute this thing down to where, we run into a problem to where nobody wants to go to medical school, because we do need people to be able to do bypass surgery and brain surgery or what have you. I mean, I guarantee you I'm going to need one of these days. And, so I would like to know that, if these hospitals can hire 3 nurse practitioners or 1 physician, that's an issue for me, So if you could get me that information, I'd appreciate it.
Yep, we can follow up with the cost. And I think just to comment about, just the different professions, nurses want to be nurses, and they go to nursing school and do advanced education. And then, physicians go to med school and do their residency. So what I find very interesting, and I didn't experience this outside of this building, but just in here, we're a healthcare team out in the real world working together to provide care for our patients and do what's best for our patients. And this turf war was something very new to me when I was in this building. So I think that no matter whether you're a nurse, audiologist, a speech pathologist, a physician, it's patient-centered care and access to care and increased, removing barriers is the point of this legislation.
And Chairman, I will agree with a little nuance. Hospitals do operate like a business. However, when I was general counsel for some small businesses, we had to look at liability issues. And you're not going to just hire the cheapest if it's going to put you on the line for being sued for healthcare issues. So when you look at the other states that have done this, a majority of the states that have actually transitioned to practice, patient outcomes go up. And that says a lot. When you look at the statistics here in the Show Me state, we've got a hell of a lot of statistics to show that this is the right move for our constituents and the state of Missouri. Yes, it's not as costly as hiring 15 brain surgeons. We want them to do brain surgery. We want them to focus on brain surgery. But when it comes to the in and out, day in, day out of patient care, let these nurse practitioners do exactly what they've been trained to do. They're not wanting to do brain surgery. They're not wanting to do heart surgery. They're not wanting to do anything they haven't been trained to, because, again, that'd be a liability issue that they would get sued and be out of work.
So all of these states that had restricted practices that go to the reduced practice like that, how long did it take before they wanted to be in full practice?
I think there's a variety of different ones. Like Kansas is full practice without any transition, so automatic full practice.
They went from restricted to the full practice.
Yes, in 2023, I believe. And I think, like I had mentioned in my remarks, I think the transition to practice with 2,000 hours is good compromise. I think it's good compromise.
Yeah, I've known providers who go, from high school to nursing school, directly become an APRN, and we want to focus on, again, the patient care, the patient outcomes, and having that real world experience. That's where I think, looking at some of the approaches that just transition automatically, there's got to be some stopgap measures, some safeguards in there for patient care. And I think that 2,000 hours is practical and is kind of right in the middle of the pack of what other states have done.
Are there any other questions for the senators? All right, seeing none. First witness to testify in favor of the bill whenever you're ready. Yeah, before you get started, how many witnesses do we have to testify in favor of? Can I have a show of hands, please? How many do we have in opposition to? Okay. Probably going to limit our test. When do we go in this meeting? Try to keep your testimony as short as possible. I want to get through everybody, so, I'm not going to put, we need to keep it like under 5 minutes.
Sure. Thank you, Mr. Chairman, members of the Senate. My name is Marcy Marcus. I'm a nurse practitioner in Columbia, Missouri, where I have practiced for 25 years. I'm a master's prepared provider. I have a nationally board certified family nurse practitioner, and nurse practitioners have a minimum of master's prepared. Okay, that's the minimal standard for advanced practice. More and more are becoming doctoral prepared, and that is more research-based, but it can also be clinical-based. Missouri ranks number 45 of 50 in the overall health care by state, and one of the worst states in maternal and child health. It's more than likely that every one of us in this room today have limited health care options at home. The number one issue in healthcare today is access, number two is rising cost, and three is quality of care. I've had to close 3 rural clinics after COVID to comply with the rules with my collaborator when he took a different position. All rural areas that I had to close those clinics, Mexico, Boonville, and Moberly, which I had served for almost 10 years. I now have just the one clinic in Columbia, but the Senate bills addressing today will address all of the needs that are for all healthcare Missourians. I've been asked specifically to speak about the cost of APRN collaboration. What used to be a teaching and mentoring tool for advanced practice nurses into healthcare has now become big business. Online companies will provide APRNs with collaborating physicians because, again, there is a healthcare shortage for physicians, and physicians are getting out of healthcare. And one of these reasons is just because of the online providers. These collaborating companies will guarantee a sign-up period of 14 days to get you a collaborator. Okay, for free market and enterprise, but what about the quality that we're getting? To what toll is this to the workforce as physicians are leaving clinical practice to pursue more lucrative relationships such as these? Physicians are becoming collaborators to the extent of retiring from actual practice or declining to be collaborators at all. This continues to deplete the number of providers available to see patients, further hindering access to care. Boone County, where I live, is where the University of Missouri healthcare system is, and yet Boone County is number 5 in deficiencies of providers needed to take care of their population. New patient appointments for primary care are over a year wait. Adolescent mental health has a 2-year wait list. Neurology has a year wait list. These numbers are not acceptable and continuing to get worse. Physicians are demanding higher and higher costs to collaborate. I personally pay my collaborating physician $4,200 a month, and I've done that for 13 years. My collaborating provider is now only seeing patients on a cash basis, no longer takes insurances, and works 2 out of 4 weeks a month in functional medicine. Collaboration mandate in Missouri is killing healthcare access. It is no longer what it once was, no longer needed, and is now hindering quality, affordability, and healthcare options. I wanted to make my comments brief so that if there are questions that I can address them, but it's just like we've
Under
seen
your
here.
collaborative practice right now, I'm assuming the physician takes a risk of liability with like malpractice.
I have my own malpractice
So
insurance.
you
and I
pay
have my
malpractice
license.
out of your pocket?
Yes, I do.
Okay, but the physician does as well, right?
Not for me, only for himself. And there was a reason. I don't have to have malpractice insurance as an advanced practice under collaboration, but I would be ignorant not to.
Of course you, yeah.
If somebody sues, whether a physician or I, and I'm only covered under the physician, that's dumb on my part because I'm going to be the one going under the knife. So I encourage every advanced practice nurse to have their own malpractice insurance no matter what.
So what would this do for your bottom line, like income wise, if this bill makes it, cross the finish line?
I can hire another provider to see patients. And I could probably go back to the other 3 rural clinics that I closed. Access to care.
Are there any questions for this witness? Seeing none, thank you. Are the other witnesses testify in favor of the bill?
My name is Matthew Lindquist. Thank you, Mr. Chairman, Senate Committee. I just want to talk briefly about my own experience. I've been a nurse practitioner since 2004, but I became a nurse in 1986. So I've been practicing for a long time as a nurse before becoming a nurse practitioner. I've in my collaborative practice, the most recent one that I was in, which was since 2011, I was paying 50% of my salary to my collaborating physician. So I was losing quite a bit of money over the course of time. He had 5 other nurse practitioners working with him, which he was doing the same with, which means he was making all that extra money from each of us, greatly increasing his wealth at the expense of all of us. He has been indicted, and with being indicted, lost the ability to practice at the hospital, which I rounded at with him, and therefore, in order for me to continue practicing at hospital, I would need to get a different physician. The hospital wouldn't allow me to continue. So I was forced then briefly to work with another physician, but rather than continue that, I retired instead. So I am now retired, but I'm still fighting for nurse practitioners in this state to have full practice authority. Medical schools graduate pretty good numbers here in the state of Missouri, but only 21% of medical students that graduate in the state of Missouri stay in the state of Missouri. We export physicians to every other state in the country, leaving us with greater shortages because of that. And physician practices, by and large, have been turned over to hospital-owned practices. As you can see by many of the coats behind me that say Mercy on them, that's who's owning physician practices. Nurse practitioners would like to be able to practice independently so that we can take care of patients, so we can see that they get the help they need. Again, I'm a psychiatric mental health nurse practitioner. The entire state is a desert in mental health. We need more providers. Nurse practitioners have the ability to give that. I leave time for questions.
So currently, when you're prescribing like Schedule II drugs, I know Senator Lewis talked about this earlier, you have to have a physician look that over before.
Currently, I am unable to prescribe Schedule II drugs because I'm a nurse practitioner in this state. We are not allowed to prescribe Schedule II drugs.
So even if we do this like reduced practice, you would still not be able to prescribe Schedule II drugs.
No,
is that right?
Under the provisions of the senator's bills, we would be able to prescribe Schedule II, which would enable us to actually give the stimulants that children need for ADHD and adults need for ADHD. Which
Yeah, but what about like Oxycontin and things like that? I don't agree with that part.
Well, I mean, during the COVID, nurse
Well,
practitioners
there's
have-
a lot of head shaking
Yeah.
out there, but
And not a lot-
Oxycontin is a Schedule II drug. Am I wrong? No.
Yeah, and there is no difference between a physician prescribing it, a nurse practitioner prescribing it, if they have the ability to do so. If you're treating pain, then you're prescribing for pain. I'm not someone who's prescribing Oxycontin. I never would. It's not something that falls under the purview of psychiatric mental health. I actually would prescribe the Suboxone to help someone get off the Oxycontin.
I don't doubt you, but there are also how many over thousands of nurse practitioners in this state that may not feel like that.
I know several physicians currently that have been indicted because of their prescribing practices of opiates.
And they should be.
I would certainly hope that that we don't see that kind of a problem with nurse practitioners as well.
Okay, any questions for the witness? Seeing none, thank you. Next witness to testify in favor of. Let's speed this up a little bit.
Will do.
If we're talking about the same thing, you know, so skip
Good
over
morning.
that.
My name
You
is
got
Dr. Casey
5 minutes.
Brow. I'm a medical doctor and board-certified psychiatrist who has practiced in the Kansas City metro area and west central Missouri for the past 20 years in all areas of mental health care, including outpatient, inpatient, pediatric, rural, and forensic settings. I was born, raised, and trained in Kansas City and attended the UMKC 6-year medical program directly out of high school. To address some of the questions that just came up, this bill includes stimulant prescriptions, so Schedule II behavioral health stimulant prescriptions. In my practice where I am, I have a nurse practitioner that I collaborate with who sees 100 patients a week, as do I, and I'm forced to review those charts and actually sign off on every one of those stimulant prescriptions, which is unnecessary and burdensome to my practice, to the other psychiatrists in my practice. In the state of Missouri, there are 500 psychiatrists for a population of mentally ill people of 1.3 million people. That's one for every 2,600 patients. I'm currently burned out. I'm 3 years from retirement. I've been doing this 30 years. I can't keep seeing 1,200, 1,300 different patients a year and adequately covering them. And I'm in the suburbs. When I worked for Pathways Community Behavioral Health Care in Clinton, in Nevada, in the smaller west central Missouri, I was the only psychiatrist for 5 counties. Currently, half of all Missouri counties have no psychiatrists. APRNs are vital. They are an important part of what we do and what we can do now to actually expand this. And so my nurse practitioners in this bill would not be able to write Oxycontin, would not be able to write hydrocodone. It would be Schedule II stimulants, methylphenidate, Vyvanse, those kind of things, which are incredibly in high demand for both children, college students, and adults now. So that's
So
one of the
what
things.
about Adderall?
So Adderall would be included, yes.
So
and that's
nurse practice,
possible.
they would be able to write prescriptions
That
for
is part of
Adderall
this.
on their own. And
Correct.
you're a physician, you don't see a problem with Adderall whatsoever?
I do not. I have worked with 5 different nurse practitioners over the course of 20 years
So
in
let me give
Missouri.
you a hypothetical. What happens if a nurse practitioner writes a prescription for somebody with, like say they're in high school, whatever, with Adderall, they go to another state
Right.
that doesn't have this, it's restricted practice, and the physician there won't do it.
Right.
And what happens then?
At that point,
Where do they get that drug?
At that point, they would have to find another person in that state that would be able to take over their care, just like they would with another physician. So that wouldn't change.
Any
What we're
questions for the
asking
witness?
for. Oh, so ahead.
Any other questions for the witness? Thank you.
All right, thank you.
Next person testify in favor of.
Thank you. Thank you. I'll keep it brief. My name's Alicia Jones Pittman. I'm the Behavioral Health Director for 42 Cares. This is with Local 42. It's a specific mental health resource for first responders. I'm a psychotherapist, so I listen and I provide resources, and I can tell you over the years we struggle to find prescribers. I meet with Blue Cross Blue Shield quarterly. They have nobody. They have no one. And it continues to be a constant struggle with them and their symptoms, and seeing how they're trying to manage it without the medication that they need has been a challenge. And I hate to say it, but I refer them to Kansas because they can get care there.
Thank you. Any questions for a witness? Senator Lewis.
I just want to thank you for everything you do. I'm a big fan, and thank you for helping our first responders.
Yes, of course.
I was once a licensed paramedic, by the way.
I'm available if you need anything.
That's why I keep questioning people. I was like, I don't guarantee you wouldn't want me treating you
Thank you.
without a collaboration of anything. Any other questions for the witness? Seeing none, next witness testified in favor of. How many more witnesses do we have in favor of? We need to speed this up. We got a lot of people to go, so let's get going. You got 2 minutes.
I'm Jaren Black. I'm a family nurse practitioner that practices in Chillicothe, Missouri, so I'm hitting more of the rural access to care. I didn't live in Illinois. I made sure I stayed on the Missouri side, but when I came out of practice, I did go to Illinois originally, just because that's the job I wanted to find, but then noticed the desert that my friends and family were experiencing in northwestern Missouri. So was offered through a hospital system to go back and open a walk-in clinic. And I will tell you, there's a very large hospital system in that town. They didn't want one. I talked to them before I did it. They didn't want to have to take on that. And within 2 years, we're seeing, during this time of year, 30 to 40 patients a day, which there would not be a physician provider if there wasn't an APRN. Prior to the 2023 law was when we were programming all this to open it, we wouldn't have been able to open. We were 2 miles too far from my collaborator. As far as collaboration goes, I've been in practice as an APRN for 5 years. I don't have to refer to him daily. He reads 10% of my charts, which is the state statute. But otherwise, I have to refer people locally to the providers that are present there. So the collaboration practice is strictly bureaucratic and to follow the laws, right? He's the owner of this, or the CEO of this group, so he collaborates with us as a practicing physician. But it would open up and allow more staffing. We don't have enough extra resources, so we either have to close our walk-in clinics or work excessive amounts of overtime if any walk-in provider's sick or anything like that, taking the burden off of him and allowing him to have his more experienced nurse practitioners off his, while he transitioned new people to practice, would make burnout for us less, right? You can only work so much for so long before you have a burnout, and then that would just increase the shortage. So mine's more of living in the healthcare desert and opening that up for people and providing more care there. Just because patients can't get into their primary care provider, not because their primary care provider doesn't want to see them, but because they only have so much time. So,
Are there any questions for the witness? You're pretty familiar with the Senate, aren't you?
I am.
Yeah, exactly.
Yeah, right.
I would have never known you guys were related by listening to you
I
talk.
get it from my mom.
Well, you got your looks from your mom, too, thank God. Are there any other questions or any other witnesses testify in favor of the bill? Hurry up, Jamie.
Mr. Chairman, members of the committee, Jamie Murphy with the Missouri Hospital Association. We are here in support of this bill. We do have our own little parameters around this. Hospital Association supports 4,000 hours to transition to practice, 1,000 hours if you have a doctorate of nursing degree, or 2,000 hours if you have prior clinical experience. We do support Schedule II stimulants to 5, and we also support allowing employers to continue a collaborative practice arrangement as a condition of their employment. To answer your question simply on why don't you just go to medical school? If it was only that easy, so for instance, there are not currently enough medical residency slots for the individuals graduating medical school. The state of Missouri, I believe it was Senator Gannon, increased. The state is actually funding 8 slots now, and it's a $2.2 million appropriation just for that 8. And nationwide, we are 2,800 slots short. The federal government increased their residency slots by 200. So it's just not simply, there's just not enough slots. And you can't move them to rural clinics because you have to have the caseload. You can't do 5 knee surgeries when LCME requires 20. So it's a logistic problem that we have. We just can't graduate enough doctors. So we're faced a lot of times with see nobody or see a physician today. So this bill would allow them to at least see an APRN.
We hear this pretty consistently with this bill, the slots. Yeah, I get that, and I know it's very competitive, but that's the doctor I want treating me.
Mm-hmm.
You know, that is smart enough to get that slot. So it's like, again, and I'm not saying that I'm against this bill, but it's like we keep talking about this, and to me, it's in the back of my mind, we're like diluting down our quality of patient care by doing this.
So what the ask here is allow nurse practitioners to treat to the fullest extent of their knowledge and triage patients. Nurse practitioners are not asking to do heart surgery. They're not asking to treat you for something that goes beyond their scope of experience.
And I have nothing against nurse practitioners, and if a physician is willing to lay their license on the line for, this person, I'm all for it.
But allow them to triage patients in rural clinics right now where there is zero access.
Yeah, but it sounds to me like this is about money, not logistic, where they just, we're busy. We want to go back and open up clinics and things like that.
Right. Well, we're here specifically because we want patients to actually have access to some sort of care.
All right. Thank you. Are there any questions for the witness? Seeing none. Any other witnesses testify in favor of the bill?
Good morning. Karen White, CEO of Missouri Highlands Healthcare. We are a federally qualified health center serving 7 counties in rural southern Missouri. Without APRNs, our 30 clinics that we operate would not operate because of the present restrictions. We are, that 1 to 6, one physician for every 6 APRNs. That limits our access to care. I don't know if you all are aware, but in the 10 years that I have served as the CEO, I've lost 3 hospitals. I have no other healthcare partners. I don't have any other physicians within the 7 counties I serve outside of 2 other counties. Okay? It's critical that this transition to practice it's a great compromise. It makes sense. It ensures that the patients that I serve, and I get it, in my 7 counties, there's 100,000 people. That's not a lot of people, right? As we look at the state of Missouri, as we look at the urban areas. But it is a critical 100,000 people to me because these are my friends, my family, my neighbors. These are the people I see at the grocery store. These are your constituents who elect you. They matter. They deserve the access to care. I don't have folks beating down my door, physician-wise, to come to rural Missouri to practice medicine. We either raise our own or we bring them in from National Health Service Corps, where they get loan repayment, which is great. I love that. But then they leave because they don't want to be in the middle of nowhere. However, my nurse practitioners are from the area. They raise their families there. They're contributing members of their communities. They take care of people the same way that I see us doing, and that's through a mission-minded, a purpose-minded, quality care team. That's the way a federally qualified health center practices. We practice via a care team. It's everyone involved in that patient's life. That's all. Thank you.
Are there any questions for the witness? Seeing none. Next witness testify in favor of. How many more people do we have testify in favor of this bill? Okay, you got 1 minute. Because I'm
Mr.
telling
Chairman,
you just keep coming in,
members of
and
the committee.
we're going to get through our debates in opposition, so hurry up.
Yeah, represent Leading Age Missouri. We're the Association of Nonprofit Long-Term Care Facilities across the state. We need more nurses. We need them to be able to practice to the fullest extent of their
Do you
knowledge.
have any questions for the witness?
And
Seeing
I
none, next witness testify in favor of the bill. Come
dropped a
on.
witness form from Nikki Strong for the for-profits
Thank you.
as well.
Mark Figgenbaum with Missouri Farm Bureau. We have member-adopted policy supporting this, and for that reason, we're in favor.
Thank you. Any questions for the witness? Seeing none, next witness testify in favor of.
Matt Thompson, Orange Juice, BJC Healthcare, here to testify in favor of the bills. Thanks.
Thank you. Next witness testify in favor of. You can have a couple minutes because you're not a lobbyist, I don't think, right?
No.
Yeah, okay.
Okay, so my name is Elizabeth Brake. I'm a psychiatric nurse practitioner. I live in rural Willow Springs, Missouri. I work with the healthcare. I apologize. I work with a healthcare practice that's out of state due to the restricted practice limitations here in Missouri. We provide mental health care services to our neighbors in Iowa and Kansas. Also, living in rural Willow Springs, Missouri, I did foster care for 10 years. We had many children come through my house that we could not get mental health services for. There's one clinic within a 100-mile radius of Willow Springs, Missouri. It's very rural. It leads people to have to go to the emergency room, overwhelms emergency departments. I worked in the inpatient unit there at OMC in West Plains. There's like a 300, when I was there was like a 300-person wait list to get in to get mental health services. So people would just use the emergency department as a revolving door. And then commit a crime, go to prison. It's filling up our, not having access to mental health care is filling up our inpatient institutions. It's filling up our prisons. We need to make a change. Also, a lot of our highly skilled nurse practitioners are leaving the state due to these restricted practice limitations. So I urge you to make a change.
What this and I don't disagree with the mental health crisis that we have in this state of the country. Period. It's a problem. But why would all of a sudden would it make it to where we're just kind of this influx of nurse practitioners coming to the state if we do this to go into mental health care?
We have plenty of them right here. They're going to other states because of these we can't find any psychiatrists to be collaborating physicians, so we have to leave the state.
Okay. So how many nurse practitioners can a physician have under them in a collaboration? Six?
Yes,
Okay.
6.
All right. Are there any other questions for the witness? Seeing none, thank you.
Thank you.
Any other witnesses testify in favor of the bill? You don't have 2 minutes. You got like 30 seconds.
That's fine, Senator. Mr. Chair, members of the committee, Will Mars on behalf of Mercy Health Systems, just want to go on record in support.
Thank you. Any other witnesses testify in favor of?
Heidi Lucas, Executive Director of the Missouri Rural Health Association. This is one of our priority bills this session, and we are very much in favor. Thank you.
Thank you. Are there any other witnesses testify in favor of?
Thank you, Mr. Chair, members of the committee. Mandy Hagseth on behalf of Missouri Family Health Council, echoing everything you've heard before, in support. Thank you.
Any questions for the witness? Seeing none, next witness testify in favor of whenever you're ready.
Derek Leffert, CEO of the Association of Missouri Nurse Practitioners, and record on support.
Thank you. Are any other witnesses testify in favor of this bill? Seeing none, first witness testify. Please hurry, Arnie. We've got a lot of people testifying.
You say hurry,
opposition to this.
Mr. Chairman, but I drove 2 hours to get here, and this is an important bill to me, and I'd like, I'd like to have my 2 minutes, please.
You got 5 minutes.
I don't know what the rationale is, and if you're in a bad mood or
You
woke
got
up on the wrong side
You
of the
got
bed
5
this
minutes,
morning,
and if you're wasting
it's a
time,
shame
and
that
if you're
you
not
treat
done 5
Missourians
minutes,
in
I'll
this
have you
way.
removed out of
It's
this
a
hearing
shame that
room.
you treat Missourians in this way, and you owe an apology to the people in this room. You don't need to be treating people like this. So I'm in favor of both of these bills. They are needed. Rural Missouri is needed in terms of aging population, the wait to get in to see a doctor. This is a needed bill while being also under the authority and license of a doctor. Nurse practitioners are smart enough to know when a case is needed. to bring in someone else or another specialist. And I think that they're educated, well-schooled, and know their trade. It works in Arizona very well. I have two friends who are married, a husband and wife. They both provide rural Arizona care and care to Indian reservations. I like to see nurse practitioners have the same rights as physicians while under their corroboration and their authority, and that they corroborate with a doctor. And so I'm in favor of both of these bills.
Thank you. Are any questions for this witness? Seeing none. First witness to testify in opposition whenever you're ready.
Good morning. It's still morning, I think. My name is Dr. David Tannehill. I'm a critical care physician. I am board certified in internal medicine, critical care medicine, neurocritical care medicine, and certified in extracorporeal membrane oxygenation. In my 20-year career in the intensive care unit, I've worked with nurse practitioners extensively. I've had dozens of nurse practitioners work with me. They're able to operate at the full potential of their education and training. And the regulatory rules that are put upon me for their oversight is not burdensome in the least. The folks that claim that these sorts of obstacles are burdensome typically come from either academia or they are business owners. They are not necessarily fully focused on what is best for the patient and what is best for Missourians. The ability for nurse practitioners to provide care to Missourians is widespread and extends from border to border, particularly if telemedicine is employed. The thing that we need to keep our focus on, and the thing that motivates myself and many of my colleagues, is that what is best for patients in our increasingly complicated healthcare environment is a physician-led, team-based model of care. If we move away from a physician-led, team-based model of care, we risk increasing the fractured and fragmented nature of our healthcare system, which is killing people every day. I see it in my ICU on a daily basis. That's really the only comments that I wanted to make for the sake of time. Happy to take any questions.
What's concerning to me when you have Mercy and BJC and the Hospital Association coming here in favor of this bill, how many doctors get fired if we pass this thing so they can hire nurse practitioners for less money?
Yeah, that's a great question, and I will admit that many of my colleagues have that same fear. There is examples from throughout the country of hospital systems deciding to go that route. There was a hospital a few years ago, this predates COVID, where they decided to replace all of their hospitalist physicians, these are specialists in providing care to inpatients, with nurse practitioners. They cost less to hire, as was pointed out earlier in the testimony, and so from a business standpoint, it is advantageous. Now, I will say that corporations like Mercy, and for full transparency, I do work for Mercy and am the chief medical officer at Mercy Hospital, Washington. I need to stipulate I am not speaking for Mercy. I am speaking for the Missouri Association of Osteopathic Physicians and Surgeons and myself. But one of the things that I am tasked with is making sure that we are using the nurse practitioners that are in our employ to the full potential of their education and training. And I frequently will counsel the physicians that report to me to say, hey, you're providing too much oversight. You need to make sure that you are allowing this person to operate the way they were trained to operate. You need, and that sort of thing. So that is something that we are doing in a responsible manner, and it's really the best method for us to make sure that Missourians get the best health care possible.
Any questions for the witness? Seeing none. Next witness to testify in opposition whenever you're ready.
Thank you, Mr. Chair and committee members. I'm David Barb, a board-certified family physician from rural South Central Missouri. I'm here on behalf of Missouri State Medical Association and Missouri Academy of Family Physicians. I've been in practice in rural southern Missouri for 40 years. I've had nurse practitioners in my practice for 30 years. I worked on the enabling legislation and on the collaboration between the Board of Healing Arts and the Board of Nursing on the current and now evolved regulations. I want to make just a couple comments. Number one, there's been a lot of reference to teams. Medicine is more complex now than it has ever been, and now is not the time to move to independent practice for nurse practitioners, they need to be part of a team. Missourians have been extremely fortunate in that we have, in fact, been one of the holdout states that insists on collaboration between a physician and a nurse practitioner as part of the healthcare team. Do we have trouble in Missouri with certain areas? We do. But to open this up for any independent nurse practitioner to practice anywhere he or she chooses to and do whatever they wish, I think is not the right approach. I will also comment very briefly on training. You may hear some today about the quantity of training, the training that physicians get between medical school and residency and their undergraduate, of course, is multiples that of even a DNP. But I would also like to emphasize the intensity of that training. There has been an explosion of nurse practitioner programs, much of which offers online education, so that individuals rarely, if ever, in a classroom, has relatively limited some very basic minimum amount of direct clinical exposure, and an additional 2,000 hours, 1 year of clinical practice is not going to make up for what I believe are some of those deficiencies. So now is not the time, in my opinion, for us to move to this. Let's look for other solutions to some of those critical areas.
Thank you for your testimony. Are there questions for the witness? Oh, Senator McCreery. Oh, sir, she's got a question for you.
Yes, ma'am.
So you said you practice in a rural area?
I do.
Okay, so I'm just trying to understand this. To me, it's about giving people that live in rural area options. So some people have the luxury of having a car and they can drive to St. Louis, and there's probably almost too many doctors there to pick from, and they're like cream of the crop first in their medical school. I'm just struggling to understand. This bill wouldn't eliminate the ability of someone to choose to see a physician, but rather it gives, my perception is it gives people that live in areas, maybe they don't have the best car, they have funny hours, it gives them the option of having access to care. So I'm just struggling. It's not forcing people to go to a APRN.
So I think people have the perception that when they walk into an office that they're going to see a doctor or a doctor equivalent. Nurse practitioners are not doctor equivalents. And I believe that there is a misperception. I can't tell you how many patients in my practice walk into my office and call my nurse practitioner doctor. Now, when you have a DNP, you technically have that capacity to be called doctor. That's what their profession has defined. But I think that is misleading the Missouri public when they believe that this substitution is equal.
I sit on the board of a community health center, and we have an amazing team of health professionals, and I think it's insulting to imply that our patients don't know the difference between all of the different professions. So I personally find that disrespectful of regular people. I think they do know. So anyway, thank you.
Right. One other comment that was made earlier with respect to having difficulty finding physicians who want to collaborate with a nurse practitioner, that is because they are in fact worried about the liability of collaborating with a practitioner who has a significantly different level of training. Many of us do collaborate. We collaborate because it's a team, because we work together, and I can tell when he or she may be needing my additional backup and expertise.
Thank you. We're going to have witnesses testify in opposition to whenever you're ready.
Good afternoon, and thank you for the opportunity to testify. My name is Dr. Dan Jackson. I'm a board certified in OBGYN, maternal fetal medicine, and addiction medicine. And I've practiced in Missouri for my entire career since I finished training. I want to applaud the discussion of a really important and relevant issue with healthcare in Missouri, especially rural Missouri. It's something I'm very passionate about. My family's from rural Missouri. What this bill does is it allows for independent practice of APPs across all specialties. We've heard a bunch of them named today. Neurology, women's health nurse practitioner, nurse midwife, psychiatry, behavioral health, and blanketly across the board. And those are vastly different specialties. Those are medical specialties where after you finish your 4-year MD or DO, you do a residency of fellowship ranging from 3 to 7 years of 80-hour weeks. And so those specialties are not considered uniform in medicine, and I think that's where this bill errs, is considering those uniform. For example, I see patients who are every day who are incredibly complex. They have a fetal anomaly, growth restriction, high blood pressure, diabetes, hepatitis, bipolar disorder, and opiate use disorder, and that was 3 yesterday. Those patients are incredibly difficult and are far beyond, I think, what any nurse practitioner, who's being honest with you, would say that they would want to see. What this bill would do would be allow for an APP to put out an independent practice and see those patients without any supervision or collaboration. I think that's unfair for patients, and I think it's unsafe for patients. I will say that throughout my entire training and practice as a fully trained and boarded physician, I've worked with multiple outstanding advanced practitioners through a collaborative team-based environment, and it has been a tremendous part of our ability to force magnify and provide care both in urban Missouri and in rural Missouri through telehealth. I see patients all over Missouri through telehealth. Probably 60% of my office visits are via telehealth in many of these counties that are underserved. Particularly relating to my specialty, this bill would allow certified nurse midwives to practice independently. To be clear, obstetrics is a surgical specialty. Most experts shoot for a C-section rate of 20 to 25%. This would mean that you have an independent practitioner who can't deliver a quarter of their patients. As multiple people have said, our healthcare population is getting more and more complex, and an advanced practitioner in the field of obstetrics is not going to have the relevant training and experience to integrate all those complications in the very real patient I mentioned a minute ago, in formulating an overall plan of care through pregnancy, antenatal testing, delivery, and postpartum care. Having been involved in working with APPs in training and in practice, it's beyond their scope. And I think that's where this bill errs, is looking at everything uniformly, because all specialties are not the same. A productive collaboration is necessary, and what this bill does, and the fault I have in it, and the reason that I oppose it as an individual, is that it oversimplifies a much more complex issue. And I'm happy to take any questions.
Thank you, Doctor. Are there any questions for the witness? Seeing none, next witness testify in opposition to, whenever you're ready.
All right, Mr. Chairman and distinguished committee members, my name is Tim Swearingen. I'm an anesthesiologist. I'm the president of Ozark Anesthesia Associates in Springfield, a group of nearly 30 anesthesiologists and 45 mid-level providers, both CRNAs and AAs. And I'm here to testify in opposition to this bill on behalf of the Missouri State Medical Association. First, I'd like to apologize if I stumble, because this is not in my wheelhouse. I had some things typed up, but in the interest of time, I would like to say that, there's been a lot of discussion about access to care. There's not been much discussion quality of care. And so I would just like you to consider the Missouri State website for their family nurse practitioner program says that they take 672 clinical hours of rotation, and many of their coursework is online. Now compare that to a family medicine physician who does a 3-year family medicine residency with the federally mandated limit of an 80-hour work week. And this is after 4 years of medical school. There is no comparison. I work with mid-levels on a daily basis, and I fill knowledge gaps on a daily basis. It is a reality. There's a study by the National Bureau of Economic Research which concluded that in the emergency department setting, nurse practitioners use more resources, leading to longer length of stay and higher spending, and they achieve less favorable outcomes, including higher 30-day preventable rehospitalizations. From a more financial perspective, there's a study in the Journal of the Mississippi State Medical Association which concluded physicians scored better on 9 out of 10 metrics. Mid-level spending was higher by $43 per member per month, but $119 per member per month if you adjusted for patient complexity. And their patients were 2% more likely to require a follow-up ER visit. So for the Hattiesburg Clinic alone, which was part of this study, this equated to a $10.3 million increased cost. And so therefore, they rolled back the privileges of their APRNs in their clinic. Now, if one clinic is $10.3 million, imagine what this could mean for our Medicaid program. This bill has been deemed the answer to rural access. APRNs can already practice in these rural deserts because there's no proximity requirement for collaborative practice. And it sounds to me like what I've heard today, we need to do a better job of policing unethical, predatory companies who are exploiting this law and not throw the baby out with the bathwater. The 1 year to transition, I think they actually said 2,000 hours, that's roughly a year. Again, with 10% of their charts being reviewed, there's not a lot of education and learning and growth happening there. You can't compare that to a medical residency where you have a practicing physician looking over your shoulder, scrutinizing every decision, every diagnosis, and every second is a learning opportunity. And Mr. Chairman, you touched on the unintended consequences. I do think if you provide a shortcut to the finish line, more people will choose the shortcut, less people will take the long, arduous road, and we could exacerbate already existing physician shortage. Last thing I'll say is Senator Schroer used the analogy of if an attorney in Missouri was being required to practice as a paralegal. I think he has that analogy completely wrong. It's the inverse. What we're talking about is, are we going to allow paralegals to start practicing as attorneys? In conclusion, I am opposed to this bill. Thank you for your time, and I'm happy to answer any questions.
That's what is my main concern, and I don't want to keep repeating myself, but my concern is these corporations. Their concern is not patient care; it's money.
To that note,
and
can I make one more comment?
if you get these, we keep talking about rural Missouri. Well, I come from rural Missouri. We have plenty of doctors and we have plenty of nurse practitioners. If I have to have my chest cracked open and have heart surgery, I'm going to St. Louis. I'm 100 miles from there. That's never going to change. We're not going to have the hospital and ever have the ability to do that in Rolla, Missouri. It's just not going to happen. So that's always going to have to be our option. You either go there by helicopter, ambulance, or your car, if you're lucky enough. But, we don't have a shortage of doctors or nurse practitioners where I come from in rural Missouri, and I come from a very rural part of the state.
Can I make one more comment?
Yes.
There was also a mention of hospital systems in favor of this. So if APRNs are cheaper to hire than physicians, that's small potatoes. If they order more unnecessary tests, unnecessary consults, and the cost of healthcare goes up, and that hospital is on a fee-for-service basis, they make more money on both ends. They pay less and they make more. If we went to a truly capitated system where there was only so many dollars for the healthcare of each patient, they would want the most educated, the most qualified person who can help keep those healthcare costs low.
Thank you. Are there any questions for the witness? Right. Seeing none, are there any other witnesses testify in opposition to?
Mr. Chairman, I'm Dr. Kento Sonoda. I'm speaking on behalf of Missouri Academy of Family Physicians and myself. I'm board certified in family medicine and addiction medicine. I completed a 3-year family medicine residency and 1-year addiction medicine fellowship. And I practice 3 days a week for primary care, 2 days for addiction medicine. And I'm a addiction medicine fellowship faculty, and also I'm a course director for addiction medicine track for residency, and also teaching the nurse practitioners for addiction medicine. So I see that knowledge gap every single day, and so that's why I'm opposed to this bill. And yes, I think we can save some money in the short run by skipping the collaboration. However, if we put someone at higher risk for addiction, we would cost more money by taking care of the more complications from substance use disorder. And also, if someone who are not competent enough to manage these conditions, the prolonged use of controlled substance would happen, and that can lead to eventually substance use disorder, sedative use disorder, stimulant use disorder, and opioid use disorder. As an addiction medicine doctor, every single day I see the negative consequences from the prolonged use of controlled substance use. It's easy to start, but it's very hard to stop. And that's why it's really important to keep the collaborations, and so that we can keep the appropriate use of controlled substance use. And for example, the common scenario is someone present to the chronic pain, and often they have mental conditions too. It's very complicated to manage that kind of conditions. That's why I do think it's really important to keep the collaboration, and so that we can provide a good patient care by keeping the patient safety. And the questions, who do you want to have your kids to see? Do you want to have your kids to see trained, well-trained doctors, or practitioners who completed the brief training? And also in terms of how to bridge a gap for someone living in the rural areas, I think there's some other ways to do it. There remote service is available. There's some other ways. So I think just bridging the gap for access to care for controlled substance, I'm opposed to this bill. Thank you.
Thank you. Any questions for witness? Okay. Senator McCreery.
Thank you. So it sounds to me like you're accusing nurses of overprescribing opioids, but yet they're not able to prescribe those. So I'm a little confused by that. I mean, if we want to get into finger pointing about who's overprescribing opioids, I would look at the people that actually can prescribe.
Sorry.
So I'm wondering how you're comfortable accusing nurses of overprescribing something they can't prescribe.
I'm not accusing the nurses to prescribe it. I think it's a matter of the choosing controlled substances in the appropriate setting.
Okay.
Thank you. Any other questions for a witness? All right, seeing none, thank you for your testimony. The witnesses testify in opposition to the bill whenever you're ready.
Hello, I'm Dr. Cheyenne Ferris. I'm a second-year family medicine resident in Sedalia, Missouri. I am hoping to provide a little bit of clarity because I'm the one that went on and went to medical school. So I started as a nurse in 2013. I had my BSN. I worked for 6 years, started a nurse practitioner program, recognized that I spent more time writing papers than I did learning about patient care. To be fair, that was in the beginning of my training. And so I'm not here to necessarily say that the training is, that they shouldn't be able to do, sorry, this is also not my thing. The training is different. That is essentially, and I know that we know that, but I am opposing the bill because I recognize now that as a resident and talking about that physician oversight every minute of every day that you are on, that is different than having a collaborating physician for 1 year and then being able to do a full scope. I'm happy to take questions or provide clarity if I can.
Thank you for your testimony. Are there questions for the witness? All right, seeing none, thank you. Any witnesses testifying in opposition to the bill when you're ready? How many more witnesses do we have to testify? Okay, we've got about 20 minutes, something like that. 25 minutes.
All right, Chairman, I'll be quick. Thank you for letting me speak. My name is Dr. Misty Todd. I am potentially the biggest proponent of rural physician-led team-based care. I grew up in rural Missouri. I believe that patients there deserve to know the difference in the care they receive and who receives it. And I'm actually the program director of the first rural residency in the state of Missouri. So rural residencies are the answer to increasing access to care by physicians. Dr. Ferris, who was just up here, I recruited her from Oklahoma. She gets it. She wants to be part of a community. She moved here. Her husband's on our police force. She delivered 4 babies last night, went to bed at 4 a.m. I picked her up at her house at 7 this morning, and that's the kind of training that happens during residency. She cares, she knows the difference, and I am there watching her every step. The difference in the hours and the people that are watching, a residency isn't one person. It is multiple physicians. So saying that oversight from one physician is enough to make you competent and equivalent to a residency, it's incapable. I work with as a collaborating physician with a nurse practitioner, and I love her. That's how team-based medicine needs to be. My husband also works in rural Missouri. He's a family physician. We both work in towns of less than 2,500 people. When we started, we waited over 4 months before we hired an NP because some of the people that are applying for the positions don't have what it takes to take care of the complex needs in rural Missouri. I tell this story to lighten the mood, but we ask everyone kind of the same questions when they interview. You know, what have you seen in your training as a nurse practitioner? How do you feel with laceration repairs? How do you feel with injections when, you know, it's planting season and I need to get my farmer back in the field because you've only got 2 weeks before it's supposed to rain again and he needs his shoulder injection. So we always ask, can you give injections? And we had multiple that said, yes, we're really good at giving injections. We give flu shots, and we give hepatitis B, and we give Gardasil. And that's not the same as knowing how to give an intra-articular injection to a patient to get them back to their life. The time it takes to train someone to be competent and to be able to independently perform things exceeds what this bill has in writing. That being said, it's okay to admit that you don't know things and to have that collaborative agreement. I have a newer nurse practitioner and she cannot read an EKG. And every time she gets one, she comes to me. And that's what a collaboration is about. Even though I'm here today, she's texted me 3 times about patient care. And if we eliminate that collaborative relationship, that means that patients in my clinic are not going to be able to get the access to care they need, but they're going to get referred on and further bog up our specialist. I'll take any questions now.
Thank you for your testimony. The question for the witness. Seeing none, next witness testify in opposition to whenever you're ready.
Hi, Chairman and Committee. I'm Taylor Laval, a medical student from the University of Missouri. While I am also from a rural town outside of Rolla, Owensville, Missouri, I'm sure you know of it, we also have this same drive to provide care to our rural folks, but one thing that we need to address is just because we open this up is not forcing nurse practitioners to go practice in these rural areas. There is not something that says you have to fit this certain need. There are physicians and reimbursement loans for us working in rural and underserved areas. I do not see that this is directly asking these nurse practitioners who are wanting this independent practice to go work in those areas where there is this need. And if we're not if we're not getting this in return and filling that need, then why are we expanding this scope? I also wanted to address something we said earlier about Missouri being one of the #1 exporters of medical students. Roughly 1,200 medical students graduate in the state of Missouri each year, and there are only roughly 600 medical student residency spots for them to match into. So clearly there's not enough residency spots, and we appreciate the GME funding and expansion, and that's our step forward. Getting more Missouri physicians residency spots. This has only had a couple years of being in place, and we haven't been able to see the benefits of this expansion yet, and that is our step forward. That's it. Thank you.
Thank you for your testimony. Any questions for the witness? Okay. Seeing none, any other witnesses testify in opposition to whenever you're ready?
Good morning and thank you.
I'm Sarah Cole, born, raised, and trained in the state of Missouri, and I'm a board-certified family physician, caring for people in under-resourced areas of St. Louis County. I am the daughter of a nurse. I have a daughter who is attending nursing school with intent to become an APRN. At work and at home, I have the utmost respect and value for nurses and nurse practitioners as members of the healthcare team. I currently serve as the collaborating physician for 3 APRNs. I will reiterate that 1 year of collaborative practice agreement does not equal 3 to 7 years of intensive residency training. Missouri should avoid setting a double standard for clinicians who wish to achieve independent practice at the level described in Senate Bill 144 and Senate Bill 179. Residencies for APRNs exist. Fellowships for APRNs exist. Missouri has the opportunity to require APRNs who desire independent practice to not only have a certain amount of time under a collaborating practice agreement first, but to be graduates of APRN residencies or fellowships. Until APRNs have completed supervised training, such as a residency or fellowship, they should remain within a collaborative practice agreement as a valued member of a physician-led healthcare team. I also wish that the theory that granting nurse practitioners independent practice would fill gaps in rural or under-resourced regions. Unfortunately, no matter if a state supports physician-led care or allows APRNs to care for patients without physician involvement, APRNs do not move to under-resourced or rural areas. A study by the Centers of Medicare and Medicaid Services showed that 25% of APRNs work in under-resourced areas, which is the same rate as physicians. And only 9% of APRNs work in rural areas, which is less than the 10 to 11% of physicians who work in rural areas. There are other and better proven strategies to effectively bring quality care to under-resourced or rural areas, including expanding telehealth services for primary care, increasing the number of physician residency positions, and I thank this body for doing so in 2023 with the Graduate Medical Education Expansion Grant. Providing loan forgiveness programs for all clinicians, including APRNs and physicians who practice in rural, under, or resource areas, and there is a bill for this, Senate Bill 635, and creating programs that encourage students from rural or under-resourced areas to pursue nursing school, medical school, or other health profession education. Thank you.
Thank you for your testimony. Are there questions for the witness? Seeing none. Are there any other witnesses testify in opposition to the bill whenever you're ready? I might remind the witnesses, too, to fill out a form if you haven't done so online so your testimony can be put in public record.
Real quick, Mr. Chairman, Jacob Scott with the Missouri Orthopedic Association, on record in opposition. There's been a lot of great testimony. I'm here every day. Would love to talk to each of you in your office to further explain why this is a bad idea for Missouri.
Thank you, Jacob. Any questions for the witness? Seeing none, any other witnesses testify in opposition to whenever you're ready?
Thank you, Mr. Chairman, members of the committee. David Jackson, registered lobbyist for Jefferson City Medical Group, which is an independent physician group that employs 57 doctors, 15 primary care, and 26 nurse practitioners. All of our doctors are in collaborative practice arrangements. We also have several rural health clinics and family practice clinics where nurse practitioners are practicing on their own right now without a doctor on site, but the doctor comes 1 day a week. They review all their charts and have a lot of collaboration back and forth between the two. It's really hard to recruit doctors to rural areas, really hard. But the question is, how hard is it going to be to get people to go to medical school if we now pass this and allow somebody with 13% of the training to do the same thing? And that's the concern. And I think if this made sense, and it was from a business sense and a patient safety sense, Jefferson City Medical Group would be here testifying in support. But they're concerned it's not an access to care issue, it's an access to risk issue. This isn't a turf battle, it's a training battle. And so I think, I want to touch on something that Senator McCreery mentioned. I mean, when we talk about patients, I think patients do understand the difference between providers. But I also don't think this is patient-driven. I've yet to talk to a senator from an urban area that's had phone calls lobbed into their office from patients or from a nurse practitioner in an urban area saying, if this bill passes, I'm going to go home and open up a clinic. Or someone from a rural area who's getting bombarded by patient calls saying, please pass this bill because this new clinic's going to open. What's likely to happen is that if your clinic in Sykeston right now that may have a nurse practitioner there with a collaborating physician, it means that they're going to start prescribing, or continue to prescribe, Schedule 3 they prescribe right now, things like Xanax, I can't remember what Oxycontin is, but Ambien, Suboxone, ketamine, and nobody's reviewing those charts. No one's collaborating and working, together to review that team-based care. I haven't heard anything today about the problem with collaboration and why team-based care doesn't work. Because we heard 2 years ago, we passed a law that completely removed mileage across the board. And that was going to be the golden ticket. That was going to solve rural health care, access to care. That ink hasn't even dried. And we're already back here again. And so, our goal is to provide more care, not less oversight, in creating more doctors and more nurse teams together. So, again, I'm here every day as well, but I would just urge the committee to look through and see what this bill does. It's not just family care. It's a matter of, do your constituents want a doctor involved when your loved ones are, getting diagnosed with cancer or prescribed Xanax, or, trying to figure out if they're having a heart attack or if they have the flu or something more severe. So with that, I'm taking any questions.
I bet family dinners would be awkward if you were for this bill.
There's a few sibling, yes, correct.
Are there any questions for the witness? Seeing none. Are any other witnesses testifying in opposition to this bill?
Mr. Chairman, members of the committee, Organ Schlam on behalf of Washington University, we deliver very highly specialized care to patients who need very highly specialized care, and it is critical for our physicians to be able to enter into agreements with APRNs. They cannot practice independently with the type of patients that we see. We have over 2,000 physicians. We have about 2,000 physicians at Washington University, and for those types of care, we certainly need to be entered into a collaborative practice agreement with the APRNs, so they cannot practice independently in those settings.
Thank you. Any other questions for the witness? Seeing none, are there any other witnesses testifying in opposition to this bill? All right. Seeing none, with no other business to come before the committee, I make a motion to adjourn. Have a second. We're adjourned. Huh?